manager follows very nicely with the single assessment tool, and we have Dr. Natalie Vereker. Natalie has a background in applied psychology with a PhD in gerontology. Previous to joining the HSE, Natalie was involved in European research in a number of other European funded projects. Her input was primarily around ensuring usability of older adults and adults with a disability. She was also employed by the European Commission in an expert evaluation of the allocation of funding of projects. And Natalie she had a part-time, she worked in the applied psychology in both UCC and CIT for applied psychology studies and early childhood education. She joined the HSE in 2002 as a manager for strategy and planning for services for older people, and she became a national specialist in 2009 and has been invited in a number of implementation of the single assessment tool since 2012. And she has numerous other qualifications and one in healthcare management. So we welcome Natalie Vereker.
Morning. As the previous speakers have said, we're here to talk to you today about the single assessment tool and basically the national implementation of the single assessment tool for services for older people within the HSE. As Tig has already previously mentioned, there is a long recognised need for a single assessment tool. Without that as the foundation, it is very difficult to plan for services and to plan adequately. It is both recognisable internationally and nationally. It's best practice that you would have a standardised comprehensive care needs assessment for older people to appropriately identify their care needs. And if only you can appropriately identify their care needs, can you then provide appropriate care in an appropriate setting, and that is right from home care, intermediate care, acute care, long-term care, and it is a continuum of care. The need has been recognised for quite some time. I suppose it first came to light in Ireland in the Least Cost Report in 2006, and prior to the introduction of the Fair Deal, there was the requirement for a standardised care needs assessment, but there was no agreement at that stage what that care needs assessment would be, and that's why we currently have the CSAR. And the CSAR is just what it is. It's a summary report of a number of different assessments which presents difficulties. It obviously is also still in the HICWA number, what was the standard 10 and actually 35 in future health as well. And as I said, we don't have one standardised care needs at the moment, which can lead to huge variation. It can lead to variation geographically, and it can lead to variation between disciplines and sometimes even within disciplines. They are currently generally all paper-based, so there is no transfer of information between settings. There's a lack of connectivity then between the hospital and community settings because people are doing different assessments and the assessments don't follow the patient when they go from one setting to the next. The system requirements, right? So we have our ICT function within the HC lead on that. But worth mentioning is the carers needs working group. As part of the previous work with the working group, one of the recommendations was that the Interray suite of tools could be strengthened in terms of how they assess carers and carers' needs. So we undertook to actually develop a new questionnaire for carers in terms of accurately identifying carers' needs specifically. So we're working with Interray, which is an international organisation. They have an instrument development committee on that. So we're working with them and our Irish care organisations to develop a new carers needs assessment, which will be part of the suite, And once we're leading it in Ireland, and once we develop it, it will actually be used internationally because...
Hello everybody, I'll just run through what the software looks like and what the interim assessment is about. So basically, as Natalie was saying, that we had our open contract and the software vendor, this is our design for the systems.
Community-based services on behalf of the HSE. We're a long time in business, but we've never heard of this, which is one of the problems we see. This is disjointed. It absolutely affects us and our ability to provide service, yet nobody has seen fit to communicate it. Absolutely no fault of yours, but this is the consistent experience. Also, two questions. When might this be fully rolled out, including all the community care individuals, and what level of access or integration will it allow from third-party providers like ourselves? Thank you.
Yeah, thanks very much. Well, essentially, I suppose you may not have heard of it because it's still in development. We're still testing. We're finalising the testing now. Currently, what we're hoping is that we would be finished implementation by late 2016, early 2017. We don't plan to change assessment structures. So the way the structures currently work at the moment in terms of public health nurses conducting assessments out in the community is the way we'd envisage that to continue. So it would be rolled out to the current people who currently do assessments. Now I know that there are slight differences depending on where you are in the country in terms of the way third parties provide services and access services. So I would imagine it will come down to the individual or the local area decisions. But from a national project point of view, from my perspective, we are going to this phase concentrates on HSE staff for the first phase. This is the first phase, which is HSE staff who currently complete CSAR assessments.
Okay, another question.
Just on that though, even under the current system where the CSARs are being completed, like the drop-down effect for us as also a third-party provider is that we have a huge amount of administration of that. So in other words, we receive those CSARs, they have to be scanned up and into our monitoring system, and so there's an administration result for us. So I'm wondering, like we've only recently completed the HSE's requirement. We had a face assessment form that we had to complete and scan up into our system, and the CSARs, we also do that. It's a huge piece of work, around 400 or so clients. I'm just wondering, so now this new inter-rate form will replace, so there'll be another whole piece of administration work for us. It still will affect us, won't it? It's not
well,
just
what it will do is that you no longer will be scanning a CSAR report. You'll be scanning a summary output from the SAT assessment, which will give you slightly more information on your client, but you won't be scanning a CSAR assessment anymore once it's implemented in your area.
So is it just going forward though, I mean, or will it be backwards onto the clients on our already in existence on our service?
What it will be people who will be going for new services, so people who will be going for home care packages, or long-term care won't affect you because you're community based. So it'll be people going for home care packages initially, and once we get that tranche out, then it could be people getting home health services.
Okay, so just going forward and not
yeah, and in that way, then you will get those people who will be requiring reviews.
Okay.
Yeah.
So there's still that.
But the first thing is it's new clients.
New clients.
Yeah.
Then my last question is just: will it only be conducted by medical professionals? There's no you know, the way with the face assessment form, managers or supervisors would complete part of that assessment. Is this purely medical professionals?
It's health professionals. Health professionals. But the training is key. Only people who've been trained can do the assessment.
Okay. Okay. Lovely. Thank you.